שלום, ברוך הבא ליוון וליתן. אני מדבר קצת עברית. אני עם אבא שלי יהודי, אמא שלי נוצרית, אומר.
Continue in Hebrew.
מעורב. No worries, I will continue in English. TAVR case. Well, TAVR case, aortic regurgitation isn't a topic that comes up very often in TAVR's discussion. All day, all night, we talk about aortic stenosis. Aortic regurgitation is an issue with some peculiarities, interesting peculiarities, and some other zestful topics. So, let's go. Our patient was a female, is a female, 70-year-old with normal body weight, BMI, BSA, etc. With a background with arterial hypertension, dyslipidemia, moderate pulmonary hypertension, emphysema, atrial fibrillation, anemia, severe chronic kidney disease, stage 3B. So she presented with a mild exertion according to the NYHA 3 to 4. But the most important thing is that she underwent 2 aortocoronary bypasses 30 years ago in 7 months. Why is that happening? It's kind of weird, but the truth is that the first surgery, instead of being anastomized, the left internal mammary artery in LAD was grafted in coronary vein. So, in order to resolve this problem, the second sender made the osteomyoplasty, a procedure called Dion procedure. The Dion procedure is an osteomyoplasty where a left main neo-osteum is grafting uses a saphenous vein. You know, with anterior approach, with lateral skewed aortotomy, and although the use of vein grafts utilize the fibrinolytic properties of the vein, it may be subject to dilatation according to published literature. Let's go back. The patient was symptomatic, predominantly regurgitation, Vmax 2.4 and mean gradient of 14. The AR severe with all these values, and the left ventricle ejection fraction was 30 to 35, NT-proBNP over 28,000. Let's go. The risk score. The patient's risk score was STS score 31 and the Euroscore 24. Some other images, echo images with the valve area was also in motion. This is the depressed left ventricle with a low ejection fraction, with the aortic regurgitation and a mild MR. The same thing. This is the vena contracta 8.5, the pressure half time, the end diastolic diameter in 65 millimeters, the end systolic was 57. This is the moderate pulmonary hypertension 56, and this is the coronary angiography, the RIMA, and the neo-osteum on the left side. According to the CT TAVI, their sizings and geometry, the STJ height was 37, the annulus, the area is 538, and the other level of LVOT 600. Both osteums, the left and right, were at 11 millimeters height. The sinus of Valsalva was quite good, over 30 millimeters. And this image, to be frankly speaking, we hadn't paid the necessary attention at the beginning. We hadn't noticed these protruding features where the arrows focus at the beginning. And we saw it in front of us during the procedure. This is the aortography. You see this radiopaque protruding features into the LVOT, apart from in addition to the filling, the robustly filling of the left ventricle and the tremendous AR. Femoral axis, the diameters of the lower limbs were okay. TAVI cusps, there was an absence of calcification of the leaflets, but there was a ring-like calcium at the base of the leaflets. The valve selection, we proceeded with an Resilia valve, Sapien 3 Resilia valve. We can discuss if you want later, why we choose that. The first reason is our center is quite familiar with this valve. This is the first reason. But there are more. This is the patient prosthesis mismatch, no problem. And this is this is the procedure. The procedure was an event regarding the gaining femoral axis and the other things, the insertion of the 14th French of insertion of introducing catheter. As can be seen by intraarterial blood pressure, the intraarterial blood pressure, the diastolic pressure was 14, 45, 43, were indicative of severe aortic regurgitation. However, when we proceeded with the orthography, we encountered these quite bizarre images. The left ventricular outflow tract, possibly local saccular aneurysms of the relevant cusps, the NCC and the LCC. Well, we had a mini meeting, as you can see here. Where is the nadir of the cusp of the valves in order to define where is the plan, where is the annular plane. Of course, a revision of the CT angiography, route was deemed appropriate at the time. After that, it lasts approximately 5 minutes in order to understand what exactly is the nadir. We proceeded with hemodynamic measurement, as you can see here, with the simultaneous measurements. Left ventricle and diastolic pressure was increased at 20, and whilst across the valve, there was a moderate gradient of 29. Following, we pre-dilated with the valve, the valve with a 22 balloon to prepare the calcified annulus for valve implantation, and the protruding features were still there, recognizable during the full balloon dilatation. After that, with this is, yes, the rapid ventricular pacing, you see, they still remain, this saccular aneurysm still remain. After that was no problem to the delivery of the 26 Resilia Sapien 3 prosthetic valve was uneventful without any problem. The expansion of the valve was performed at nominal 2 ml plus 2 ml volume in order to achieve a 10-15 overexpansion, just lower from the predefined annulus plane, with a rapid ventricular pacing. After that, we thought that if we decide to slowly decelerate the rapid ventricular pacing in order to avoid a large stroke volume that could be, let's say, lead to valve migration or embolization, etc. As can be seen by the revision aortic root orthography, the prosthetic valve was perfectly implanted. An interesting observation was that the placement of the prosthetic valve sealed the coronary, non-coronary, and coronary cusp aneurysm, 2 in 1. The post-implantation hemodynamic measurements show a normal diastolic pressure at 75, no gradient across the valve, of course. And as expected, increased left ventricle and diastolic pressure, and therefore was commenced with diuretic treatment. We explicitly avoided post-dilatation since the mechanical interaction between the dilated prosthesis and the native valve may not provide a secure anchor at the aortic ring because of the absence of leaflet calcification, potentially probably increasing the risk of migration during post-dilatation we're afraid of. So we leave it as it is. And of course, the right femoral axis point was sealed with MANTA, vascular closure device, without any sequel. This is the day 3 of discharge, the echo, without any paravalvular leakage, regurgitation, etc., and the disappearance of the MR. quite strange. That is. So, thank you. That's what.
So this is an amazing case. Arik, would you do something different? Would you use a self-expanding platform in this case or not?
No, can you go back?
Where?
Don't go out of the. Can you put it on?
During the procedure or?
Yeah. First of all, thank you for really an amazing case. I got to admit that I wouldn't have been as brave as you are. No, I'm serious, because when I saw those two fistula or aneurysm, I don't know even what to call it.
Yeah, sacral aneurysm.
Whatever. I would have lost my courage and stop. But have a look. Put it to the implantation. And of the valve.
Yeah.
Wait a minute. Because what's important, have a look.
No, this is the balloon inflation. When?
Yeah, okay.
First,
go to the balloon inflation first. Go back to the balloon inflation.
Uh-huh.
And you know, we are learning a lot from the CT and the pre-procedural. I'm talking to you, Danny, and the pre-procedural imaging.
This was.
And sometimes, no, go to the balloon again. And sometimes I learn from the balloon inflation so much. And this made me worried for the first time, because it was not like straightforward. But then go to the implantation. Now have a look.
This was not, is recognizable. That means that the balloon inflation doesn't seal these aneurysms.
Yeah.
And was sealed there, yes. Yes,
then go to the implantation and have a look. We're used to see the implantation of a sapien 3 or whatever you call it now. It shortens like 80% from below, 20% from. Have a look now here.
Yeah.
Have a look. Look at the point. Look that it does not shorten almost nothing from below. And let me be honest. It's a wonderful result. And it saved the aneurysm as well. But it saved it not because of you, not because of nobody, just because of luck. That it did not go up. It was hooked somewhere in the bottom, and it made the valve behave like he wants, not like you want it. And the result, you can't argue, is wonderful.
That was, we were thinking about it.
I know.
And we did it not by luck.
No. I'm not saying this as a criticism or compliment.
Yeah, understand. Of course, understand.
This was frightening, and the way it behaved is not the way that we know. And if it does not behave the way that you are expect or anticipate, you are just based on luck. And I don't love to be based on luck.
I think it first of all, Dimitri's fantastic case, because it's really rare, right? So it's really interesting. Only the pictures are interesting, and I see the points that you made that are also very interesting. But I think it is the LVOT that has the aneurysm, isn't it? It's subannular left ventricular aneurysm. I would say so. It's not the aortic bulbus which has the aneurysm. So it's like the subannular left ventricular aneurysm, also underneath the valve, supporting the tissue, which is very rare, which do have most of the times, or if we get lucky, small neck. It's like a spurium on the femoral arteries. So maybe, just maybe, you can never know. In this case, if you have like a subannular left ventricular aneurysm with a small neck, like a spurium, it is then the case that with the skirt, you can practically next time, not for the first time, because now we know, do treat the aneurysm with cautious, stepwise implantation, controlled implantation. That's the way you did it in this scenario. So I find it very good that you brought us this case. Thank you.
Very, very interesting. And would you consider there is not a lot of calcification, right?
No.
Were you worried about
No,
having
no, I wasn't worried because they have
It was not absent.
a ring. It was not absent at all. There was a ring-like at the base of these leaflets, not on the leaflets.
And Dr. Ntarladimas.
Congratulations on an excellent case, excellent presentation. I mean, unimaginable. What I would like to ask you is, what do you have an idea what caused those sacral aneurysms? Was it part of the surgery? Was it something defective?
It was probably iatrogenic from the
Surgery.
No, maybe it's an excellent
go back to
cardiosurgery
the angles
achievement.
of the patient.
I have no idea about that. I'm looking to his history, but nothing revealed.
It's amazing that whether it's a short valve and it closed it, whether you
Yeah.
would expect
Yes.
quite the opposite. And I would like to ask you, would you, in retrospect, consider a dedicated valve like the ENA, the trilogy valve for this case? Have you anticipated, have you observed clearly the aneurysms in pre-TAVI scanning of the patient?
Jena valve is not dedicated for aortic insufficiency, but with regurgitation. I mean, but I don't know what will be happening when we have to do with these aneurysms. It's a completely different approach only. Yep.
So any benefit of using a self-expanding valve platform in terms instead of balloon expandable? Would you consider
Self-expandable?
Yes.
No, because first, as I said before, that the majority of our valves in our center is BEV. The second reason is the patient was 70 years old. That means that we need something, a block calcium technology tissue, like Resilia, okay? Because for life longevity of the valve. Yes. And the third is that we are exploring to the radial force, the position exactly at the annulus, the short height frame, the skirt, the ceiling skirt outside. All this point to better anchoring of the valve than a self-expand, in my opinion. That doesn't mean that will be true. That will be, for us, was more secure to do that.
Okay, good. So thank you very much. So we're changing the session.